We can display the today's banner in the meantime. Yeah.
Please start.
Should we start? People will keep on joining.
Wait 2 minutes, let people join.
Another 3 minutes, huh? We'll start by 4:35. 3-4 minutes.
Hi, Navita, we can start.
Yes. A very good evening to everyone and a warm welcome on behalf of Mumbai Association of Physical Medicine and Rehabilitation. We promise that we bring the experts from all over India and all over the world globally, and we fulfill that. And in this series, today we have finished 1 year, and this is the beginning of another year where we have with us the expert in spasticity, Professor Rajiv Ribai. I would like to invite Dr. Abhishek, who is the president of MEPMR, to introduce Professor Rajiv.
It's my pleasure to introduce Dr. Rajiv Ribai, who is Professor and Head, Department of PM&R at British Columbia, Vancouver, Canada. He is the top guns in spasticity management, neuropathic pain all across the world. He has multiple awards, papers, including Patricia Klugen Award for Excellence in Teaching. He is director of the New Westminster Rehabilitation Medicine Specialty Clinic, also co-founder of the Kidney Advances in Neuroorthopedics for Spastic Congress, also one of the pioneers in starting something called as Musica program. All of you last in IFNR got some taste of it. So I hope continue to work with Rajiv in future on using ultrasound in spasticity assessment and management. So please, Rajiv, floor is yours. You can start your talk.
Thank you so much to all of you, Navita, Abhishek, and a lot of friends that I met in Mumbai in March. It is 4:05 a.m. and I would only do this for you because I really like your group. And today it is a fresh start for you, but it's also a very nice for me to be given this opportunity. I thank all of you in Mumbai because I'm going to be talking about two or three very novel concepts when I talk about the concept of botulinum toxin use and multimodal. So today will be the first time that I'm presenting this slide deck. So I'm really proud to say that. So thank you, Navita, Abhishek. And today we thought maybe about half an hour of presentation, and then I would like to open it up to more discussion. Just going to share my screen, Abhishek. Okay. Okay. Do you see it?
Yes.
Everything good? Perfect. So again, thank you so much for inviting me. I'm really honored to be here on this platform. Today, I like to talk more about the concept of multimodal treatment, so really focus on that. But you can see my title, I
I
have
can't see your
something.
slide, Rajiv. You can see Navita?
It's there. We can see.
Can you see? Yeah.
Something
Yeah,
wrong
yeah,
with
it's
my,
there.
I
Roll
can
off.
see something wrong. Okay, I just
Okay.
log in again. Yeah.
Yeah.
Okay. As I was saying that, if you look at my title, I've put spasticity syndrome. And this is something new. We've been talking about spasticity for many, many, many years, but I think we have to evolve and switch to this concept of syndrome. So I'm going to talk to you why this is important and how we can actually use botulinum toxin as a tool in this multimodal management for spasticity syndrome. And today, my objectives will be to highlight the evolution of the definition of spasticity, because spasticity itself, the terminology is going to be the concept of the spasticity sensus strictu, which means that it is a part of the upper motor neuron phenomenon. But the spastic syndrome is going to be the evolution of looking at neural and non-neural components in this whole concept of the syndrome in its entirety. And the reason it's important is that if we understand the terminology, we can then better understand how the treatment modalities can be focused for better patient outcome. So then I'll move on to looking at neural and non-neural components in spasticity syndrome, because that is very key as I tell you about how to actually choose some of the multimodal treatments for spasticity management and spasticity syndrome management. And then we'll look at botulinum toxin as a tool in this whole concept of optimizing the management, both multimodal and adjunctive management in spasticity syndrome. Now, I know many of you are starting your career, and some of you are old, like us, Abhishek. Um, you know, it's interesting that although we're moving with a lot of technology, we're also moving with a lot of evolution of definitions. If you look at the first definition of spasticity, the upper motor neuron features and the phenomenon, it was actually coined by Little in 1843, this term spastic rigidity in muscles in hemiplegic patients. Even the term contracture was actually outlined in his original paper. Sherrington then moved on to look at decerebrate rigidity. Again, you can see the terminologies, they're using rigidity in cats and not really looking at the term spasticity, but implying that there's something going on with stretch reflexes, even when we have a lesion. And then Danny Brown really looked at this concept of increased amplitude stretch reflex, again, teasing us with his definition of spasticity as we know it. And then Burke and Ashby moved on, looking at hyperreflexive state and muscle tone. So again, talking about the concept of tonus or tone. And then Landau looked at the concept of spasticity as part of this upper motor neuron feature. Then we all know for our fellowships and our training, and I'm sure in Mumbai as well, that Abhishek, Navita, and others are teaching their residents to memorize the 1980, 1981 definition of Lance. If I were to pick on someone, Abhishek, I'm sure everyone probably remembers this definition by heart, that it is a motor disorder characterized by a velocity-dependent increase in stretch reflex, being the muscle tone, exaggerated tendon jerks, as part of this hyperexcitability of the stretch reflex, described as one component of the upper motor neuron syndrome. So again, this is something coined in our brain, and when we're doing a paper, we're always, referencing this paper. But you can see that the definition has even evolved with Dwyer et al. And then Pandian et al., which is a definition that I really, really like. And Anand Pandian with the Spasm Consortium in 2005 in England, they looked at the concept that can a noxious stimuli trigger this tonus, this hyperexcitability from the upper motor neuron feature being spasticity? And the answer is yes. And this is where this definition is really interesting because it's talking about sensory motor control resulting from an upper motor neuron lesion presenting as intermittent or sustained involuntary activation of muscles. So you can see that we have evolved from Little, moving on to Lance, moving on to 2005 Pandian. So the question, do we need more definitions? It seems every 3-4 years there's a new definition. And you can see that Grassis then moved on to look at velocity-dependent phasic stretch. And then 2017, Van der Noort, not a definition, but a proposal to look at maybe there's something else that is causing the tone. Maybe it's something other than upper motor neuron phenomenon. Could it be the muscle? So that they were first in 2017 to look at a non-neural component. To confuse you more, Dressler, our German colleague, looked at this concept of the sensu strictu. So spasticity sensu strictu, meaning that it is a very much the central phenomenon is called spasticity, so upper motor neuron lesion. So he coined that term. And then you can see we moved on to Baud et al., and my colleague in France looking at the concept of velocity-dependent reflexes to phasic stretch. So you can see everyone is playing a little bit with Lance's definition, adding a little bit more and confusing us more. Isn't that correct, Abhishek, Navita? It's making us more. So what are we doing? What are we treating? Now, I'm going to confuse you more. We've actually coined a new definition in 2026, which we just published last year. And we thought there are too many definitions. We don't treat a definition. We don't treat a definition. This is a problem. A patient doesn't come into your office and say, oh, Dr. Abhishek, Dr. Navita, my elbow is tight. It's a modified Ashworth of 3 or Tardieu of 20 degrees. Treat me. How many of you have had patients like this? Well, very, very rare. But we don't treat a definition, but we need to understand the definition to treat the patient. So what has this new concept of the new definition? So it's a working group of about 20 of us who got together in Houston in 2024. And if you can look at some of the authors, they're some of the authors of the original definitions. So we were able to get Gerard Francisco led this initiative with Shang Li. They have a definition of spasticity. We also have Professor Anand Pandian. We also have Professor Dressler on this committee. And we also had invited Professor Jean-Michel Grassis. Lance, unfortunately, passed away in 2009. But again, in his honor as well, we wanted to look at preserving these definitions and not making a new definition, but making it more clear of what is needed to coin the concept of spasticity sensu strictu. And you have the QR code here. So please take this QR code down. It's a downloadable open access journal. Now, Are you confused yet? No, I'm not going to confuse you more because I'm going to tell you why we needed to do this. So this is what the new consensus definition of spasticity is. This is the newest definition, but what we have done is take an honor and really look at each definition that has been published over time, even from 1983 Littles to all the way down to our definition, is that it is now the consensus definition is as follows: a disorder of sensory motor control resulting from an upper motor neuron lesion or disease. We've taken away the lesion to disease. It is characterized by velocity and length dependent involuntary muscle overactivity, which is intermittent or sustained during passive stretch. So why is this important? We have combined the conceptual definitions of Lance. We've also combined the concepts of the sensory motor from Pandian. We have now fine-tuned of what it is. It is a disorder of sensory motor control. It must be. And then it is not just a motor disorder, it involves impaired sensory motor integration resulting from the upper motor neuron disease. Where it comes from, it is an upper motor neuron disease rather than a lesion. So this again can be anything that can affect the upper motor neuron pathway. It synthesizes the Pandian definition and the Lee pathophysiological definition of spasticity in stroke proposals, and also involving the cortico-reticulospinal and vestibulospinal pathways. And then how is it elicited? It has to be velocity and length dependent during passive stretch. So again, you need to have these three very important concepts to be equal to a spasticity sensu stricto. So this concept of an upper motor neuron disease, a disorder of sensory motor control, and it has to be involuntary muscle overactivity, intermittent or sustained. And this definition deliberately excludes clonus and spasm, and I'll tell you why, because it's very important as we treat the patient. Okay, so welcome to your new chapter in your webinars, and for us, it's a new chapter in spasticity management. That this definition now is going to be a working definition for all of us. Now, we move to the spasticity syndrome. Now that we have clarified what we need to do from a definition from an upper motor neuron disease, and we have now looked at this concept of we can have tonus, hypertonicity from a lesion in the upper motor neuron system, but can we also have tonicity or increased tone from the periphery? And this is what this working group, the ToxNet group that I'm involved with, this is 19 of us from all around the world, we looked at this concept that what we're treating is not spasticity. Because so when a patient comes to your clinic, you're looking at multimodal treatment, you're stretching. Are we treating spasticity only, the upper motor neuron feature? Yes, we can be, but we're also treating a syndrome, the non-neural factor. This is where the definition of spasticity is very important to understand, that the upper motor neuron phenomenon, but there's another phenomenon happening at the periphery. And you have the QR code for this new paper. And incredibly, both papers got accepted in the same week, a week before this presentation. So I've taken, I added these slides in Vita because we discussed, I want to teach you the highest level in that the new concepts are emerging, and for you to decide how to incorporate it into your practice. So now let's look at the spasticity syndrome. What is it? Well, here it is, and this is a publication, and this is a QR code. It's a constellation of neurological signs and symptoms secondary to an upper motor neuron pathology, accompanied by non-neural peripheral soft tissue changes. So in order to have the syndrome, you need to have the upper neuron signs and symptoms. You also have to have the non-neural peripheral changes, and this equals spastic syndrome. Do you see why this may be important? Is because now you can look at treatment of modalities that can go into that bigger box, or you can also treat the non-neural peripheral changes, or you can treat both of these boxes to look at better gains from outcome. So let's look at this box. As many of you know, in order to have an upper motor neuron signs and symptoms, you have signs of spasticity. And now this is from Dressler's concept of sensu stricto. So you need to have spasticity by itself, an upper motor neuron phenomenon, as I described it from the new definition of spasticity X. You can have clonus, exaggerated reflexes, associated reactions, dysynergias, pathological reflexes. You can have sustained involuntary muscle overactivity. And this can be also including spastic dystonia. You can have spastic muscle paresis. This is from Jean-Michel Grassis' coined term. And then you can have co-contraction spasms. You can also have decreased motor control during voluntary movement and the symptoms of stress-induced pain. You can see we've included pain in this concept because pain can be directly triggered by spasticity. Intrafusal fibers can actually trigger this change in the dorsal horn evolution of this trigger of pain. And then we can have the non-neural peripheral changes, which equals spastic syndrome. Now, to me, this is really nice because now you can compartmentalize and get better treatment modalities. So again, in summary, why this distinction matters clinically. In order to actually understand this better, I put these 4 boxes for you. The diagnosis and measurement is key. So you can't treat something if you can't know what it is, and you have to understand what the definition is. So that's why the strict definition by Spasticity X that I just described to you makes clinical assessment operational. So if you just look at spasticity by definition, it's an operational concept. You don't just treat spasticity. It has to actually trigger a functional change. It has to trigger a problem, but it can also trigger change from a syndrome, potentially changing neural and non-neural components. So that's why the strict definition makes clinical assessment operational. It guides the correct use of scales, such as Tardieu, modified Ashworth, and modified Tardieu. It distinguishes the velocity length dependent neural component from tissue related one. So it's good to know that someone has spasticity. Okay. Now we move to multimodal treatment planning, which I'll talk about today. The syndrome is better for us because it allows us to gauge where our treatment can go. Is it central or is it peripheral? And this spastic syndrome concept reminds clinicians that the clinical picture often requires combined intervention centrally and peripherally. For example, the toxin, physical therapy like stretching, contraction management like orthoses, casting, shockwave to really look at this muscle fibrosis to try to break the fibrosis potentially at the muscle level. Transcranial magnet to maybe look at the concept of central modulation. It also allows us language. Like today, what I'm hoping is that to give you strict guidelines of language, what is spasticity? I've shown you the evolution from the 1880s to 2026 spasticity X definition. So again, understanding an upper motor neuron disease, it has to be velocity dependent passive stretch. So having 2 distinct terminological levels, operational, which is the spasticity X definition, the sensu stricto, and then descriptive term, which is the neural non-neural component spastic syndrome, reduces communicative ambiguity amongst us, neurologists, therapists, and researchers. So this is important for us having the clear nomenclature. And then treatment personalization. So understanding that non-neural component is important. So fibrofatty infiltration, contractures, shortening of the muscle tendon complex along neural ones, the spasticity definition by spasticity sensu stricto can allow us to better gauge our treatment. So I hope this is a good platform to move now because it's important to understand these very important concepts. Now let's move into the concept of non-neural component because my belief in the research that we're doing and also where the evidence is moving is that if you don't think about the non-neural component of the spasticity syndrome, you're going to miss the treatment opportunities and also to get better patient outcome. So by just treating a modified Ashworth or Tardieu, which we have been doing for generations, this is wrong. We have to look at functional issues, but we have to look at treating the spasticity, sensu stricto, or the spasticity X new definition, but also looking at the non-neural component. And this is where I want to introduce you this concept of increased muscle tone, not only because of upper motor neuron, but also because of shortening of the tendinous muscle junction. So we know that elastic and velocity independent plastic resistance are enhanced in long-standing spasticity, and this can actually cause increased muscle tone at the muscle. Yeah. So if you can put mute for the, yeah. If you look at the muscle, if it shortens, it's going to get tighter. So when you're doing an assessment for neurological exam for tone, you may actually be getting a little bit of tonus because of the muscle becomes shorter. Now, this muscle shortening and this muscle change has been seen in cellular studies, animal studies, and human studies that if a muscle post-stroke, for example, it becomes atrophic, it becomes smaller. And what happens? You get extracellular connective tissue, fat deposit, and this fibrosis can generate. There's also epigenetic gene control that can express changes in muscle fibers from type 1 to type 2. This makes a muscle stiffer. And then you can have hyaluron, so you can have stiffness of the fascia. And what this can do is that this can actually make the muscle get stiffer and give us this change in hypertonicity. This is where, when we're using the modified Ashworth scale, the modified Ashworth scale is quite interesting. And Abhishek, Nivita, you can invite me for another talk about the problem with the modified Ashworth, is because we believe that it's actually looking at muscle tonus, not the central element, because the modified Ashworth does not have a velocity dependency in when you do it. It's actually a very slow torque movement. So you need to have velocity in the definition, correct? So it actually is looking more soft tissue retraction and potentially assessment of contracture. This is where the Tardier scale is better for assessment. Now, I move to fat infiltration because this is a very important concept. If you don't see the patient who has spasticity identified early and you don't treat them early, you're going to have more fat deposit in muscle. This can change this whole concept of skeletal health. It can make the muscle tighter because the actual fat can actually express genes that can change the type 1 to type 2 fibers faster. So if you can change the fat deposition, so you allow it not to accumulate more by stretching, by movement, by looking at potential neuroplastic maneuvers to actually get more muscle strength back, then you could actually decrease the chance of the type 1 to type 2 fibers changing. This is a hypothesis. And if you can early, then you can actually have better outcomes. Botulinum toxin can neuromodulate agonist-antagonist action. So if you have someone who has a flexed elbow and the biceps brachialis is very tight, spastic, okay, it has a modified Ashworth catch, it's got a Tardier catch velocity dependency, you can see that maybe there's non-neural component. You can actually inject botulinum toxin with a multimodal program with stretching, casting, for example, TENS neuromodulation. But you can also look at the antagonist, correct? So if you can balance the agonist antagonist, you can get more strength in the agonist. And this can lead to better strength potentially in the muscle and changes in the fat infiltration. And I'm going to just not confuse you more with a higher level epigenetic, but this is real. If you have more fat deposit in a muscle, these are in sarcopenia studies, you can actually have more inflammatory responses, interleukin, tissue necrosis factor, leptin. This can change the epigenetic of the muscle to want to change the fibers, and this can change into fibrosis. This can give you decreased strength, mobility, and give you hypertonicity at the muscle level. So you can see that fat could be a very important concept to really target in research and elements of synthesizing our plan. So when we're doing early intervention, by looking at spasticity management, we're not only decreasing the tonus from a upper motor neuron syndrome, but also the tonus from the muscle. So we may be modulating the fat, and this is a theory that we should be looking at. Now, many of you know that I'm passionate about ultrasound. Ultrasound is not only about injection and targeting the toxin, but we can also look at potentially viable tissue to inject the toxin. There are many studies now internationally going on that we're looking at, can we inject the toxin into darker areas that are more viable tissue? As I've told you, there is a change of fibrofatty infiltration. Here you can see a patient with a right MCA stroke, the left affected limb. The muscle is smaller, atrophic, a flexor carpi radialis and pronator teres. You can see more streaking or fatty infiltration, the white eco-intense picture that I have. And this eco-intense hyperechoic streaking is evidence of likely fibrofatty infiltration, fat infiltration, collagen. And again, I told you this vicious cycle of fat regenerating and changing fiber types from type 1, type 2 is likely giving us this whiteness. But you can see in this image, there's some darker pockets here. So the theory now is that can we modulate the muscle by putting the toxin better positioned in more viable tissue? And can this give you better outcomes in a multimodal approach? I believe the answer is yes. Many of you have seen this concept of the modified HECMAT, a semi-quantitative way to assess muscle architecture. It goes from 1 to 4. Just want to briefly tell you about you can, with your eyes, already look at what's happening to the muscle. Here's an example of a control muscle. This is normal echogenicity in greater than 90% of the muscle. So the muscle looks very healthy in this area circled. In the second image, this is pronator teres in a patient with a stroke. You can see this fibrofatty streaking. And why am I showing you this? Because it can make you better decision makers when you're even looking at multimodal treatment. And then you can see here 10 to 50% of tissue has increased echogenicity, but the other areas are normal muscle echo. Now, what's interesting, spastic muscles, is that the whole muscle doesn't get affected all the time. Some neuroplastic changes, we have pockets that are still viable. And these pockets actually are important for treatment modalities, I believe, for looking at for the injection of the botulinum toxin. Now look at this other muscle. This is a patient with multiple sclerosis. This is a medial gastroc. It's looking really more unhealthy. There's more areas of whiteness, hypercoicity. There's some dark pockets, but almost 50 to 90% of the tissue in this image is reduced, decreased bone echo from bone echo. So there's increased whiteness, echogenicity of the muscle. And if you look at the fourth one, it's a modified Heckman of 4, very strong muscle echogenicity with near complete loss of distinct bone echo. So more than 90%. So you can see it's looking very unhealthy. Now, it doesn't mean that a muscle that is looking like this does not have range. Patient who is very rare, but 10% of patients having a muscle that looks like this can still be amenable for toxin injection. They still may have some range of motion. It may not be a fixed contracture, but the trend is that a muscle looking like this in modified Heckman 4 is looking more unhealthy, and we may even have EMG changes that can show decreased insertional activity. This is a study of ours a few months ago looking at sticking an EMG in muscles that are looking like modified Heckman 3 and 4, so the more increased eco-intense. And what do we find? That at least 80 to 90% of the muscles were unhealthy. So there was decreased insertional activity, meaning that we have to really look at these muscles earlier, really keep on stretching early, identifying them even 3 months within the stroke, because we can have these architectural changes that can make the muscle stiffer, the tonicity from the non-neural component, and we need to be more aggressive for treatment, even maybe look at neuroorthopedic strategies rather than just pharmacologic and multimodal treatment. Okay, so now let's move to the crux of my talk. How do we choose multimodal? Well, we have to look at concept of early intervention. Jörg Wissel at Qualital showed very, very beautifully that you have to treat patients early because we know in observational studies by up to 2 weeks after a stroke, you're going to have 25% of your population having increased muscle tone. This is from the central mechanism. Then by 12 weeks, you're going to have problematic spasticity. And then if you don't treat well, within 6 months, 52% of these patients are going to have a contracture. This is a whole crux of treatment. We do not want to have a contracture. So what do we need to do? Position. So we want to stretch, even before botulinum toxin. We want to look at orthoses, potentially looking at modulation. Electrical stimulation has level 1 evidence with adjunctive therapy with toxin early in treatment. So is casting and orthoses. My belief is that if you see a patient within a month having evidence of spasticity on the Tardieu scale, again, we're not treating a definition, but we're identifying them early. So if a patient has hemihyperesthesia, they're weak in the muscle, so lower than a grade 1 MRC score in the pelagic limb. They have a low Barthel index, so they have they have high Barthel index, so they have a high care need. They have a very decreased quality of life score, and they have 2 or 3 joints having modified Ashworth of grade 1 or more. These patients have to be identified early and also early potentially for even botulinum toxin injection with multimodal treatment. And this is where the risk stratification is very important early for treatment. And here's a very nice study by my colleague Alexandra Picelli from Verona, Italy, showing exactly this concept. They looked at a cohort of 83 patients followed prospectively, and they said, okay, if you see a patient's before 3 months compared to after 3 months, and if you inject botulinum toxin with multimodal treatment, which group does better? And they showed that the earlier you treat with a multimodal treatment, the better it is, meaning that if you treat after the 3 months, these patients had higher MAS score, modified Ashworth score, and poorer functional outcomes compared to the patient treated earlier. So early is better. So now, in summary of everything I've talked about from the spasticity X definition, the spasticity syndrome concept, is that you have to look at neural and non-neural component when you're treating the spasticity syndrome. Because, as I showed you, that within 1 month, you can have the atrophy, shortening of the muscle, increased intramuscular connective tissue, increased fat content within even a week, triggering this vicious cycle of changing the rheological properties of the muscle. And this contributes with the upper motor neuron syndrome, this vicious phenomenon. And that you can see here this vicious phenomenon that can lead to higher contracture formation. So again, earlier we treat, earlier we neuromodulate. It could also help with neuroplastic changes. Now, we all have seen this 2018 guideline for management spasticity. This is from the UK guidelines that we have to look at multimodal treatment in spasticity management. It has to be team-based, collaborative, goal-oriented. We have to look at general and focal interventions. So you can look at general interventions, can be posture management, seating, bed positioning, as easy as that. You've seen that sometimes a patient is seated improperly, like an MS patient, they start getting a wound, a pressure sore. That wound can trigger the sensory motor trigger of spasticity, and this can be vicious. So if you have to take away that trigger, even before we start injecting, even before pharmacotherapy, then we can have focal spasticity, and we know that it's level 1 evidence to look at botulinum toxin for focal spasticity in the American and Canadian guidelines. And this is very important. And with the generalized interventions like physical management, like stretching, this could be key. And then we can also have oral agents if it's more than focal, some multifocal spasticity or general. And if it's truly general, you may even look at multimodal treatment with baclofen pump. And then botulinum toxin can also be added, even if it's multifocal to general. So I think you all are familiar with that, but it's important because now let's move to the concept of what is multimodal. Now, I'm saying multimodal. Yes, it's adding things. We know that. But is there a definition? Many of you guys know me. I like to get definitions when I'm teaching because if you don't have the right definition, it's difficult to actually understand what you're doing. So this is a paper that we did a few years ago to do exactly that, because in literature, we found that many of our colleagues were mixing the terminology between multimodal and adjunctive therapy. So let's clarify this. There are many modalities for treatment spasticity. If you add more, this is multimodal. The way that we like to divide it is localized and reversible methods. So you can see from constraint-induced movement therapy, exercise, taping, casting, bracing, shockwave, electrical stimulation to focalized injection of toxin, phenol, alcohol. We can then look at localized and permanent methods, tendon lengthening, soft tissue releases. Sometimes we have to do it in conjunction with the localized and reversible methods. This is more for contracture management. You can also see general and reversible methods, as we have here from exercise, oral therapy, stretching, transcranial magnet, intrathecal, to more general and permanent methods such as selective dorsal rhizotomy. But how do we choose these modalities? So before we choose, we have to look at how this concept is important, is that multimodal therapy, the definition is the addition of one or more therapeutic modalities to current intervention or interventions to reinforce the effect of the treatment plan. Multimodal therapy is to be considered to optimize goal attainment if initial therapeutic interventions have failed to achieve specific goal. So let me give you an example. You have this patient that has spasticity and spasticity syndrome. We're then doing slow passive stretching, TENS, orthoses, toxin at the muscle level to help the wrist flexion attitude to optimize the chances of achieving a specific goal. The toxin can be added as one of the therapies to this existing plan as a part of the multimodal plan. And theoretically, I'm going to talk to you about adjunctive therapy. You can add something directly to the toxin to enhance effect within part of this multimodal plan. Now, when we look at multimodal plan, the way that you should look at it is, again, from our publication, is it's not just looking at sprinkling, but you have to have a thought process. I like colors. You can see from green, pink, red, orange, and blue. And you can see, for example, if you have someone with pain and spasticity, then think about the level 1 evidence of multimodal strategies like passive immobilization, like stretching, rehabilitation, e-stim. So electrical stimulation, self-rehabilitation, stretching, and passive mobilization have shown to help pain management in some RCTs. So again, choose some of the modalities. Let's move to strength of antagonists. So You want to strengthen the triceps so you can get better ability to move the biceps. So by decreasing the triceps spasticity, so you can do strengthening exercises, physical therapy, occupational therapy, self-rehabilitation. And you can look at in yellow, you want to improve the rheological strategy. So make the muscle less stiff so you can get less tone. So you can do taping, casting, splinting, physical therapy. These are all level 1 evidence. So if you have these modalities in your clinic, use them as long as it doesn't do harm to your patient. And again, I like to combine these modalities, and I like these color combinations because they can all combine each other. Now you can also see, I forgot to say that active goals, so someone has reached, grasped, and you want to really get to that active goal faster, is better to add more modalities than just one. But passive goals may not require as many modalities. So again, this is under research. We're looking at this in our lab, but this is a conceptual thought process right now in choosing and how many do we need. So more is better. And why a combination therapy is better is because of neuroplasticity. If we choose different modalities at different levels, being brain, spinal cord, peripheral. So for me, if a patient comes to a clinic and I want to choose multimodal, what do? I choose something that can hit the brain, a modality can hit the spinal cord mechanism and the periphery. So for example, for me, I like low-hanging fruit, as we say. I like to do stretching, it's free. So stretching, we have to do that as a self-rehabilitation program that can help with the rheological properties in the muscle. How to stretch there, this is a problem. There are very few protocols giving us definite guidance, but again, stretching is key. Then we can use TENS neuromodulation. TENS can work at the spinal cord. It can help pain. It can also neuromodulate spasticity. We know that in some of the very nice systematic reviews and RCTs. So again, this is an example of targeting two modalities to help. Then we can inject the botulinum toxin at the muscle level, but it can also have central effects. So this can help us for rheological properties, but it can also promote good neuroplasticity that could theoretically trigger CNS changes for better functional outcome. So again, to show you that at the pathophysiological level, the multimodal treatment approach is key. Now, let me move to adjunctive therapy. As I kind of showed you, adjunctive therapy can reinforce the effect of an intervention. So for example, botulinum toxin, we're injecting it, we add something else. For example, you may not have enough toxin in your clinic for that patient that day, or there's not enough coverage for the patient, or potentially you only allowed 1 or 2 rounds of toxin per year for the patient. So if you add something like casting, inhibitive casting, up to 10 days after the toxin, it has shown to allow the duration of effect of toxin to last longer. So you may need you may have a longer window for the next reinjection cycle, up to even 6 months. Similarly, electrical stimulation can potentiate the effect of toxin. And then you could also have shockwave therapy with the toxin injection. So a day after to 3 days after, 3 cycles that could actually help to enhance the effects of the botulinum toxin. The key in the definition is that the time after intervention should be either immediate, 1 to 3 days, but it cannot be more than 14 days after the toxin injection. So in order to be adjunctive therapy to optimize the effects of the botulinum toxin, it has to be within 14 days. And that's the difference between multimodal, which could be at any time. And again, just in summary, why do we use adjunctive therapy after botulinum toxin injection? To improve uptake and or toxin efficiency, can help reduce the toxin dose injected, and can help increase the interval between injections and may improve patient outcomes after the toxin administration. Now I'm going to tease you with another concept. What if we are looking at it the other way? What if physiotherapy, exercise, electrical stimulation, casting is a primary modality, and then we add the toxin like a neuromodulator? So we're not enhancing the toxin, but we're enhancing the physio, exercise, stimulation, casting. So could the toxin do the other process by adjunctively increasing the effects of physio, stretching, exercise, stim, and casting? It's possible, and there are ongoing studies to get better results and to see if you can get better results. I talked a little about this concept of motor command, and we should all look at that. So when you have a patient, and this is a very simple analogy of the elbow, you have a biceps and brachialis spasticity, but a triceps antagonist. It has basically a co-contraction. Also, you have this unwanted involuntary command movement, meaning that the triceps get really tight. How many of you seen that? You're doing your modified Ashworth tardieu, you're sure that there's spasticity in the elbow, but then it's very difficult to extend, and there's a catch also in the triceps. So which one is a chicken and the egg? Is it the triceps or is it the biceps brachialis? So it could be both. It could be that the triceps is very, very much an antagonist player where it should be relaxing, but is spastic. By injecting some toxin multimodal, we can then allow more rheological change in the biceps and strength. So we can actually increase strength. That's why when you're using electrical stimulation, you have to use it both on the agonist and antagonist. So if you're injecting in biceps or brachialis, maybe think about also rheologically changing properties in the triceps. So sometimes you have to inject in the antagonist muscle. So this is where this concept of multimodal is important because we can then look at this reduced inhibition, increase excitatory response to increase the force in the agonist and antagonist. So again, if you're treating the biceps brachialis, don't forget about the antagonist muscle. So now in my final slides, I want to look at how do we choose? And I like to classify it. If you're going to choose multimodal adjunctive therapies, it could be patient factors, so time since upper motor neuron pathology. So if I see a patient a week after a stroke, big hemorrhagic stroke, and you're seeing that they're getting some catch phenomenon, I'm going to observe. I'm going to observe, I'm going to stretch. I'm not going to jump to botulinum toxin injection, casting. But what if the same patient in 2 weeks now has hyperesthesia, a very much high care needs, they have a motor, have zero in the MRC scale, but we're sensing that the tone is really getting worse. And they have one or two joints, MES, modified Ashworth score of 1 plus or 2. I may treat this patient early, potentially with a little dose of botulinum toxin, with stretching, with an orthosis, because this patient may actually get more problematic spasticity very early. So that's why looking at neural, non-neural component and the pathophysiology early is important. How about physician allied health factors? So what if you don't have manpower for stretching, physio? Then you have to teach them yourself. What if you have access to a shockwave machine, e-stim, a TENS machine? You probably will use it. So again, resource dependent, but also evidence-based. So right now the evidence is that if you have the following tools, if you have ability with electrical stimulation, TENS neuromodulation, shockwave, casting, orthoses, and stretching program, those are all level 1A evidence to consider. Transcranial magnet is coming along right now, but again, we don't have enough evidence to say that we have to use it. But if you have it, there is good proof of concept and some good randomized control studies, albeit small, that neuromodulation in the brain could be interesting. So again, if you have it, you're not doing any harm to the patient, consider it. But this is how I like to look at it. My final slide's looking at a scoping review by Arirat Supiretata and looking at what are the best modalities. So she did this very nice study last year, and they looked at all the randomized control studies for stroke. So what kind of modalities, non-pharmacologic and pharmacologic, can help in spasticity management? So these are the grade A, so high level. Stretching, as I said, static stretching with positional orthoses, transcutaneous electrical nerve stimulation, TENS, shockwave, repetitive peripheral magnet stimulation. Few studies, but there's a signal that it could be useful. Non-invasive brain stimulation, botulinum toxin A, dry needling, intrathecal baclofen, whole body vibration, and local body vibration. I really like these diagrams, this concept of a bubble mapping. The bigger the bubble, the more randomized control study. You can see out of all the modalities, botulinum toxin A is the biggest, but it's not the only one. You don't just go and use botulinum toxin by itself. It has to be used within a multimodal plan. But can you see what's interesting? Even dry needling, shockwave, stretching, these are big bubbles here. And the lesser darker blue, so darker blue, very, very high level. The lighter blue, not as much, but even acupuncture has shown some concept, CIMT, constraint-induced movement therapy. But again, protocols are lacking. But what I want to show you that there's evidence to choosing your modality. And in summary, when we're treating, look at the goal attainment scaling. So are we achieving the goal? Yes or no? And if it's not met, look at a multimodal strategy. If it's not met, then stratify looking at neural, non-neural. Maybe we should be looking at more multimodal strategies targeting neural and non-neural. You can see in my little cartoon here, even look at adjuvant therapy to enhance one of the therapies within your multimodal plan. All these boxes here, electrical stimulation, transcranial magnet, pharmacologic shockwave TENS, these can work either on the brain, spinal cord. We can also have rheological modalities like shockwave truly on the muscle or botulinum toxin. We can look at casting TENS as well that could work on both neural, non-neural. So again, think of it that way and look at active goals that it could be better to add more than less to actually get a better effect. And I'm going to kind of stop here, Abhishek and Navita. I have a case that, if you want me to run through, but if we have,
We can
more
take one case,
questions.
Rajiv. We can take one
Yeah,
case.
and I'm going to just summarize in the case right now quickly. And here's a case that you've all seen. This is a 52-year-old in my practice with an ischemic stroke about 6 months ago, right hemiparesis. Now he's complaining of shoulder pain pointing to the pectoralis major with passive shoulder abduction as we move the shoulder. There's also tightness of the right thumb and finger flexor dig into the palm. This is what she tells me is tight, doctor, going into the palm. We all have seen that. She does not like her use of her arm because of pain. She tells me it's a non-functional right arm and hand. How many of you have seen this case? Probably all of us. But what's interesting, she comes to my office holding a purse on this non-functional arm. So even the arm is non-functional. It could be functional in a different way, right? We're not thinking about it, right? And then she comes into my room. She turns the light off because she doesn't like the lights in my office. It's too bright for her because she gets migraines. So she's using her arm like that. So is that non-functional? So again, you have to be careful, right? That the term. But let's look at the limb. It's passively minimal extension of the index, middle, and fourth digits. So it's difficult for me to extend it fully. The thumb is digging, but as you can see in this picture, I'm able to bring it out of the thumb in palm deformity. On the visual analog scale, she has 6 out of 10 for passive shoulder abduction. Increased difficulty dressing. She tells me she needs one person, her mom, to help her. Difficulties putting her wrist orthoses on. And she has a little bit of flickers of movement. And she has an ability of maybe grade 2 of movement of shoulder abduction. Her tardier scale, so she has a spastic catch. So V1, I'm slowly moving the limb, and it's 180. And then V3, fast catch, is at 80, so 60-degree spastic angle. Similarly, the thumb has a spastic catch of 10 to 20 degrees. So she has spasticity by the definition of spasticity X. She has multifocal spasticity. She has a few, but she also has a focal spastic problem at the elbow. So we're looking at potentially using botulinum toxin with multimodal treatment. So my goals are to decrease shoulder pain when passive stretching, because I told you that spasticity can induce pain. I want to improve ease of dressing for her mom to have less caregiver time. I also want to don the orthoses for a bit longer. So this is what I did under ultrasound guidance. I did injection of pectoralis major, brachioradialis, brachialis, 100 units each, FDS, 2 and 3, 25 units each, and flexor pollicis longus, 50 units each. Now, for all of you training, this is not the only thing you do. You can't just inject. You have to package this with a multimodal treatment. So this is what I did. I did a home stretching program. I also used TENS neuromodulation, the agonist antagonist. And you can see just for you, and I can share this template, and this is published as well, Abhishek and Navita. This is what I use in my clinic every day. I look at each goal, and I use a goal attainment scaling. And I think many of you are familiar. And I use a Likert scale. I'm not going to go too much into detail, but to show you that in color, red, pain, dressing, orthoses, and a Likert scale and this is what I do to look at objectively if I'm making the goal. So for example, pain, we always start at a gas of -2 and basically 7 out of 10. And then we're trying to see, can I go up to a gas of +2, 1 out of 10. So if I can do a really good job and you want to make it challenging for you, then I can hit the target. Dressing, is it difficult to less difficult? And use of hand orthoses, I can don it for longer. So use a Likert scale for that. And basically, she met all the goals. So I met at baseline. She had gas of -1 for her. So this is my starting point. Although she started at -2, which is she was really having a lot of pain. But you can see she's improved after my injection, my stretching, my TENS neuromodulation. And I also added shockwave therapy to that, ease of dressing. But you can see the only thing is that I'm not hitting the goals as much for shoulder. Is 0, meaning that I'm happy. But you know what I did? I actually changed her treatment a little bit, and I'll show you what I did here. After 3 rounds of onabotulinum, I was still hitting 0, meaning that I'm hitting the good gains. So goals, meaning that I'm doing a good job, but could I do better? So Abhishek, Navita, I'm going to ask you, what do you think I did to actually optimize her? Because, I did everything. I did ultrasound guidance, I did multimodal therapy, I did 3 rounds, and I thought, you know what? I'm doing okay, but I want to get to a gas of 1 plus, a plus 2, right? You know what I did? I changed her toxin. So I actually changed her botulinum toxin to abobotulinum. I thought maybe let me change. She didn't have basically antibodies. I checked it frontalis EDB, but what happened is that I changed the toxin, and then with the multimodal program, I actually got better decrease in shoulder gas of plus one, more ease of dressing, and I also had better use of orthoses. So in summary, when you're looking at multimodal treatment, and this is maybe a bit higher level thinking that I proposed in my last case, that you got to examine the goals, you got to get the patient caregiver involved. Like this is functional away. So I didn't want to take away too much of the elbow because she was holding it for holding like a purse with it. So I didn't want to completely make that arm go down. But also I was looking at this concept of could we switch the toxin as well if you're having suboptimal response? So again, look at the multimodal concept. In my you saw the bubble here, review the objectives and always think about adjunctive multimodal, but also think about the toxin as being part of the multimodal, that every toxin that you have, I don't know what you have in India, but in Canada, we have access to three toxins, onabotulinum, abo, and inco. That could also be part of this multimodal strategy. So, and this is my little recipe as I end. So individualized treatment program, early identification of spasticity, think about neural, non-neural, solid history, look at the positive, negative impact of spasticity, and then team-based approach, and then end with really looking at this adjunctive therapy and multimodal as you fine-tune your treatment paradigm or prescription. Thank you.
Thank you so much, Rajiv, and kudos to you. It was amazing, and as always, this was a very nice presentation. And I'm sure everyone has all the PGs have learned, and we also have learned a lot of it. It's a multimodal management. We are ready to take the questions, and I request everyone to type in the chat box so we can take the questions with Rajiv.
Thank you so
Only
much.
one comment or a question from my side. The case which you showed. So after changing the toxin, the the pain was 2 on 10 of the
Yeah,
shoulder.
yeah.
So can we do a suprascapular nerve block, so which will help in reducing the pain, because it is again, because as you told, it can be a um, non-neural, so it can be the muscles, the shoulder, which while the brainstorm staging, coming from the flaccid to the spastic stage, there can be some subluxation or a malalignment in the shoulder, and that can also be the cause of the pain. We see a lot of post-stroke shoulder pain, and the spasticity along with the post-stroke shoulder pain, they always go hand in hand.
Yeah.
So that's
And
a
Navita, yeah, no, it's absolutely it's part of the algorithm that I also consider. So absolutely, in this case, we did not do a suprascapular nerve block. She came in for pain, and maybe in retrospect, that's a great point that you could have started with a suprascapular nerve block. You can
Mhm.
then see whether that's a noxious stimuli itself, triggering that from a non-neural component, or it could be neurally triggered as well, correct? From the spasticity.
Yes.
So it could be a differentiation to look at how much of it is actually spasticity
Mhm.
sensory type 2. So really beautiful to do it that way. In this patient, because a lot of the for me, a patient's coming in and we're thinking, can we do everything at once or not? And yes, you could do an algorithm where you could do that. You could do a suprascapular nerve block, and then you could see whether the pain does go down from a diagnostic, but also from a therapeutic. You can then see the true spastic catch after that. So you can do in combination because I do that often. Sometimes I even do a glenohumeral injection sometimes if the suprascapular is not working as well. And then I look at this kind of entity from retraction of the capsule of the shoulder that's causing pain, and that's a noxious stimuli. So absolutely. So that's a great, and there's some algorithms, as you know, have been published looking at suprascapular nerve block as part of the management of shoulder spasticity. So you would do the assessment. You want to see, because the problem also, is it a weakness issue, right? So the muscle is weak, Is it a spasticity issue that is not allowing the muscle to be strong, right? The agonist, antagonist. And is it a pain issue, sensory motor, that is triggering that? That's why I'm hoping that it was going to spend a little bit of time about the definitions, because you can see how it becomes almost like you're almost like a private investigator, right? You're trying to find out which one is it. So it becomes fun. And when I'm training my colleagues and my trainees, it becomes fun for all of us to see what it is. So brilliant point, Navita. So in retrospect, in this case, maybe what I should have done is actually done a suprascapular nerve block. And then I would have seen, okay, what is the element, and the pain would have gone down. But what is interesting though is that I still believe in this case, I didn't do a suprascapular block, but I think her pain was actually driven more by spasticity, Navita, because you can see how the toxin reduced that pain really, really quickly. Now, onabotulinum did a good job, but when I switched to abo, it was interesting that I got a way better response. And that's why I was telling you, like, sometimes the change and switch can be part of the multimodal strategy. Now, this is something I do. I don't know if you've done this before, but I have seen when I've done everything correctly and I'm kind of plateauing a little bit, my gas is hitting just zero. Zero means that for many of you who may not be familiar with goal attainment scaling, it means that we've done an okay job, we've done a good job, but can we do better? So you want to get your next round to make the gas even more challenging so you can hit that goal. But it makes you want to push more. So I think, this is how we have to think that patients talk about, we talk about, oh my God, the toxin's not working anymore. But is it maybe that we're not sprinkling enough multimodal strategies to make the toxin work better? If it's truly not a neutralizing antibodies, right? I don't know. I think it's worth discussing. Maybe
Yeah.
writing a paper, Abhishek and Avita, because I do think it's an interesting concept. Yeah.
I think most of our patients in the inpatient rehab with
Yes.
acute stroke, subacute stroke, we always do a suprascapular, we do a shoulder screening, look
Yep.
at the shoulder, the glenohumeral joint, the bursa, the tendons, and then do a nerve block. Many patients actually have effusions. So Navita drains the effusion, gives a block, and then most of the time, 50% of the time, patient gets pain relief, better participation in rehab. Then if they
Mhm.
don't do, then we do botulinum toxin, especially in subacute strokes. This helps quite well in most of our patients.
No, and they
But
have
you have a
some
question? Yeah.
yeah, and Abhishek, sorry, it's a good thing that you're doing as a protocol, and once you start doing it in your strategy becomes almost, second nature. So it's very, very good. Yeah.
There's a question by Gaurav. A lot of stroke patients have hip external rotator spasticity plus minus contracture. What do you suggest? Diagnostic nerve block option before getting botulinum toxin or no?
So interesting. Yeah. So I like that question. So it depends if it's a look at function. So if you're looking at goals, are these active, passive? So is this someone who's ambulating? Is this someone transferring, right? It does make a difference, right? So if this patient is using that leg to pivot transfer, for example, right, is not an ambulator compared to someone who's ambulating, you want to be a bit more cautious. If this is a stroke patient, because it's likely theoretically more static compared to a multiple sclerosis patient, because this is where the diagnostic nerve block is a brilliant idea. And I do use it all the time in my clinic. So for me, if I have someone who's ambulating, a community ambulator, basically independent with his ADLs, IDLs, high functioning, before I jump to the botulinum toxin, I know that there is actually spasticity, so sensu stricto. So we have the upper motor neuron and maybe an element of the non-neural component. I likely will propose botulinum toxin, but I like to do a diagnostic nerve block. And the reason I like to do that is to choose the right muscle and also to be sure that I'm not weakening the patient and then having 3 months to wait until the next round or 4 months to then decide that I should have reduced it or changed the dosing. So sometimes I like doing a diagnostic nerve block to see, is it a contribution of weakness? Is it a contribution of spasticity? Or is it a contribution of contracture? So this is where the nerve block can actually help me differentiate the following. So in this case that my colleague said, for the external rotator, so you're looking at, and Gaurav, maybe you can specify more. So in this patient, are you looking at patient with hip abductor kind of spasticity, or like looking at glute med, and or what are we looking at from the challenge of this case? so I can better direct
I
you
think
of
it looks
what
more like piriformis being tight.
like piriformis, yeah.
Yeah, it
So
looks
you
like
can do an
that. Yeah.
intra, yeah, if it's piriformis and if it's even the glute muscles or you know what I do? I do intramuscular block now, and I find this is a very nice way of doing it. So rather than actually doing the branch in the motor branch, looking at the looking at potentially sciatic and kind of going down, and what you can do is that you can actually go. If you look at piriformis, you can actually do a few things to your point, Navita and Abhishek, looking at the MSK way of doing it, I do two things now. Sheng Li taught me a very nice concept of looking at the fascia as well. So, what I like to do, I like to actually fenestrate the fascia. So, what I like to do, and is, I forgot my colleague's name, who did the
Gaurav.
question?
Gaurav.
Yeah.
Gaurav.
Gaurav. So I love the question because what I would do in this case, if it's a piriformis, for example, giving this pattern, could it be that there's also the non-neural component? So could you take a needle, right? And then could you maybe fenestrate the fascia? So what I do with Shang Li says using a 19 gauge to 21 gauge, but I use 25 gauge, which I use for my injections. And I like what Shang Li developed. And I use the ultrasound and I go into the fascia before I inject the toxin. And I do a fenestration for about 10, 20 times. I do in plane to try to release it, almost like dry needling because as you know, there's some evidence. And then you could do that and you could do the toxin, or you can do the intramuscular nerve block. So what I would do, you go into the muscle, you find basically the branch into the piriformis, and I would just do a halo around that area intramuscularly. And I sense, in these muscle groups, like for one, the ones that I use a lot is like tibialis posterior. I'll use it for gastroc medial head um, in my clinic, rather than doing a very precise nerve stimulation, I can do an intramuscular block. It gives me a quick answer, and I do this in my patient with multiple sclerosis all the time because it gives me a bit of a thought that am I going to weaken them or not? And sometimes diagnostically it helps, but it also helps with their pain, right? So I'm kind of doing two things from the if it is piriformis. So I would say yes, consider intramuscular block. If you're going to do an actual stim, it's very rare for me to target piriformis, to be honest. If I'm looking at glute med, could be one of the other components. It could be also the perineum muscles, taking the leg out externally as well. I've seen that, looking at the external rotators being more distal. Um, Sometimes it could be the paraspinal muscles as well. The muscles are tight, right? The leg is weaker, so the muscle is weak, and the glute medials are weak. So you're using the paraspinal. So you have more myofascial pain rather than true spasticity in that paraspinal. So I say yes, diagnostic nerve blocks in this situation would be good. Then you can specify, is it piriformis? Is it glute med? Is it, glute, intermedius? So, that to me would be a nice algorithm to use. Yeah.
I think just to add, what we can
Yeah.
also do is give some local lidocaine 2% in the
Yep.
muscle. It
Yep.
works like botulinum toxin. It gives you better
Well,
such.
it's
There are papers
it was
now on that.
it
But
was
I
the
do a lot.
old-fashioned way. When I trained Abhishek, we used to do it blind. Like I wouldn't suggest you doing it now. But when I trained 23 years ago, what we did is we did a test of intramuscular lidocaine, and then because like botulinum toxin is very very, it was not on formulary, so we had to choose carefully. That's how we did it. But now with the evolution of the block under ultrasound, I think you could do even a better job. So if you're doing a block for those in the call, we use 2% lidocaine as part of the French guidelines. So 2%, 2 cc to block a nerve or nerve a motor branch. And I do that under ultrasound. I use stimulation if I'm looking at planning for surgical intervention. So if I'm looking at, which muscle is the culprit, should we do a neurectomy, of musculocutaneous, then I will use stim. But some muscle groups, as you know, if you're doing it daily, like musculocutaneous, for example, they're very easy to find under ultrasound. And you can do a very nice block, from a diagnostic. I agree, Abhishek. So you're right. In fact, I have a very small cohort. I don't know if you guys have seen this. It's very, very rare, but I've met less than 5% of patients. If I do a block, sometimes just the block with multimodal treatment
Yeah,
seems to
Yeah.
work.
yeah.
And I can't explain it, but I think it's because we're breaking a pattern, we're neuromodulating, and then it goes on. So it may be interesting to study that group. Yeah.
So in many of
Absolutely.
our, I think in many of our patients, what we do in same sitting, Navita will do a nerve block, suppose for muscular cutaneous, and I might do a botulinum toxin for the wrist flexors or finger flexors, and after 1 week, both become better.
Mhm.
So there's a lot of work on combining nerve blocks and along with botulinum toxin in same patient in same
Yeah.
sitting.
Yep. Now, the thing is that it's interesting you say that. Now, before we were avoiding injecting at the same on the same day. So because it was thought that, you could change the CMAPs, you could change the endocytosis of the botulinum toxin. But the French guidelines are very, very nice. They say that the patient comes in, has a diagnostic nerve block. You can inject within 30 minutes the toxin. So for me, you could do it within the same sitting, okay? Because before we were kind of bringing them back next cycle. So no, you can do both. For me, I do both at the same time. I think it's a wonderful, the diagnostic nerve block and also therapeutic block is very, very interesting. And then Navita, as you said about the pain as well. So that's why I love Spasticity Clinic Day because my brain is, I think we all are like kids, right? We're thinking, well, what can we do better, right? That's what I want to show that multimodal as well, thinking neural, non-neural with the block, with a toxin. That's why the toxin, would you agree with me? It's a neuromodulator, it's a tool. It's not the primary intervention. I think this is where we go wrong. Um,
Absolutely.
Abhishek, there's another question by Gaurav again, talking about
So before taking that
the
question, Rajiv, I'm
current.
sorry to
Yeah,
interrupt.
yeah.
That
I think it's
yeah, coming cryoneurolysis. Before we
yeah,
talk about that, so as you were saying about the fascia, so
yeah.
we did have some. We have started doing this in the myofascial pain as well as the spasticity. We had some few of our patients where and there was a spasticity in the back muscles and the paraspinal, and we did thoracolumbar fascia injections, and the
Yeah.
gliding and the spasticity reduced and the propensity to fall backwards, and with that the alignment of the limb also it improved a lot. So I think so all of us are doing for the betterment of the patient, yes, whatever
And
modality. Yeah.
I think when I presented, you saw like the dry needling. I never
Yes.
understood the concept of dry needling, but when I was reading these articles, there is something rheological that's happening. You're putting the needle many times, and is it also the needle effect? Like when we're injecting, we should not underestimate what a needle can do. So
Yes.
this is another concept. Are we actually changing the rheological properties? I think we may be. So what I'm doing now in my practice, and I want to do a study on this, I'm actually using the fenestration technique. If I have a very nice plane, if I've got an in-plane approach, I'm going to fenestrate it, and then I go down to do the toxin after. Right now, I have not been looking at outcomes, but I wonder if the combination of the technique as you proposed, Navita, interesting for a study, could it improve? And I'm going to lead on to this question by Gaurav about cryo because yes, there's been a lot of signal movement towards that. But right now, we don't have enough evidence to place it into our guidelines. I mean, I propose a lot of these bubbles I showed you and even the publication. We have not put cryo in there because the randomized control studies are lacking. All the studies I've proposed to you today have been RCTs. So there needs to be more research. And there's also an issue with cryoneurolysis. And Professor Winston has done an amazing job to really highlight that this could be a tool. So I think it's an interesting tool. I think cryoneurolysis has been around, nothing, it has been around for a long time for for geniculate nerve blocks, for osteoarthritis, orthopedic surgeons have been doing it for years. It has been shifting into use in spasticity over the last 6 years. Um, Paul Winston and myself, we did one of the first case series on that. But Paul has taken a championing this, and Paul's doing a lot of research on it. The answer, Gaurav, I think right now to actually say that it is part of the uh, algorithm, it can be a tool within the algorithm, but right now we need more evidence to really show where it is because what we need from the investigators doing cryo, which patients are the best candidate? Who do we actually select? Why do we select a patient for cryo? And which percentage of the patients that we've done with when we failed with everything? I don't feel that cryo is the first line. I believe that cryo is like phenol. It's a cleaner version, theoretically, of phenol. We need to also understand the pathophysiology of how does cryo actually work. So these are questions as scientists I want to know. to the point of needling, if you have a 19 gauge trocar, these are the big trocar that goes in muscle, you got an ice ball going. Is there rheological properties that are changing as you put this trocar in the ice? It could be a positive things for scientists looking at cryo. So could it be a dual mechanism that you have this trocar, you have this change, and it neuromodulation of the non-neural component. Then you have the ice effect on the nerve, almost like a theoretical nerve block. And then you have an effect on spasticity. It's just wonderful, right? So I think I'm looking forward to all the colleagues who are doing these randomized control studies and research, and I'm looking forward to a publication to really make it clear for me how I'm going to utilize cryo. So I do believe it is an interesting tool in the toolbox. I'm still trying to figure out how I can put it in clinical practice, at least for me right now. But I think it's very interesting. But it's very difficult to say that it is as effective as toxin until we actually have more RCTs to really showcase that claim.
I think Dr. Navita does both cryo as well as phenol.
Do
So
that, yeah.
we
And
can
I
answer
love
this
your point. I
question.
mean, so how do you triage? Like, how would you choose a patient for phenol versus cryo? What is your
So,
decision,
so,
Navita?
we do cryo phenol, and yeah, cryo is something where I think you are right in because we have done quite a few number of cases of cryo as well, and phenol we have been doing for a long period of time. Cryo, if it's a chronic patient, I would definitely. And when there is a nerve is when you block a nerve, or phenol is when it's not a focal spasticity, then we should go for cryo. And chronic cases, definitely cryo or phenol, both. Now we have to find out which one is a better tool, because phenol is very cheap, it's easily available. For cryo, you have to make available all the things. So I think so. We have to do again. I'm waiting for good evidence based, so that we can try each that which patients to take. Though we
I
did
think,
get good results in cryo as well.
yeah, and I
So
think it's a tool. I think Gaurav has another question is that botulinum toxin is very expensive in India. I was wondering if it's worth investing in cryo. Gaurav, my personal, I love your answer as well, Navita Abhishek. I think as a clinician, it's good to learn all modalities, right? It's very important. The issue with cryo, I believe, it has to be in hands of experts that have a lot of evidence, lot of practice. So you need to understand ultrasound because you can't do cryo blind for spasticity management. You have to understand and EMG, stim, because you want to be looking at stimulation as well when you're looking at going closer nerve. You have to have good hands as an injector as well. So I don't feel cryo is one where, for even for my residents, I'm opening them up to learn about cryo, but it's not something where you jump to be an expert right away because even phenolization, I believe that the experts who are phenol experts are the right group to really, learn cryo because you've done the phenolization for a lot and the ultrasound. So for me, I would answer it, Gaurav, that it's not just jumping to cryo and this is the answer. No, you have to learn what spasticity is. You have to learn the syndrome. You have to learn ultrasound. You have to use stim. So it requires a lot of training before you can even get to that level. But if you are, then yes, it could be a good modality. But I do not feel that it's going to replace everything that you do because there is a cost also to cryo. And I would say potentially we're underutilizing phenol. I believe that we have in North America, we should be using more. We had access issues. I love phenol because you can spare nerves to inject toxin in areas that you need it. So it's a sparing modality, Navita, for me. So you could use phenol and toxin together,
That's what we
potentially.
do. That's
Yeah.
what we do.
Yeah.
Patients
yeah,
who have, especially chronic patients, when they have very tight wrist, but
Mhm.
not that tight elbow. So if you do phenol or cryo to a mass 2 or type of patients, it can cause some weakness also.
yes, absolutely.
That's the whole point. Mass 2, 1+2, you can give botulinum toxin. When it's 3 and beyond, you have to try for phenol or cryo or a combination of both of them together. But
Agree to this
don't
because
jump to
cryo,
cryo so early.
yeah,
Give
yeah,
phenol first. Get your nerve block first well.
absolutely. And in the algorithm, it should come later on rather than coming first. They should not be the first choice of
I
modality.
I fully
Yeah,
agree. There's
next.
also I believe it has a role,
Mm,
Gaurav, but I think it's a role for probably a 10% selection of my patient. That's what I'm sensing. I don't feel it's a first line. If it's the only way to prove that is an RCT that will really show us that this is a way to shift. but I think we don't have that evidence yet.
Yeah, thank you. I think so. We have taken, and that was a wonderful interaction, and we have answered all the questions and cleared all our doubts. Though we are again, this is science, because one doubt clears and the another doubt comes, and that is how it this is how we evolve. But it was a wonderful session, Rajiv, to have you with us, and I'm sure everyone will have taken the advantage of your teaching. And we have those who have missed Rajiv's talks. They can DM me, and then we can send you the recording so that you can again learn it. And it was wonderful to have you, Rajiv. And I would have some comments from our secretary, Dr. Amit Mamre, and then we can close the session.
Thank you so much.
Thank you. Amit, are you there? I don't think so. He might be there, but I think so. The connectivity is not so good. So, with Abhishek, thank you so much, and everyone for a wonderful participation. And we look forward. We'll be coming back. We'll be sending our next presenter and next session and the next month. And Rajiv, we are thank you so much. And you got up in early in the morning, and I hope your day goes well.
Thank you
So
so much. And I would say thank you to everybody, Navita, Abhishek, and everyone on the call. It was a wonderful platform. I enjoyed this. Isn't it fun just to discuss
it is. It
and,
is.
uh, and collaborate and exchange? So I love it. So thank you so much. Have a great day, everyone, and please keep in touch. Okay.
Thank
Thank
you.
you.
Bye-bye.
Thank you so
Take
much,
care.
Rajiv.
Bye-bye.
Thank you.
Bye-bye.
Bye.
Bye.